Hello, welcome to today's webinar. Today we are doing the webinar Reducing Post-Discharge Potentially Inappropriate Medications Among the Elderly, a multi-center electronic prescribing intervention. We do have two presenters today, and I will introduce them shortly. I will just do a quick review of today's session. We will have a Q&A session as usual right after the presentations. And so please submit your questions during the presentation, and we'll try to get as many possible. At the very end, you will see that we've left both presenters emails, as they have agreed if we don't get to all questions that you could send them directly to them. At the end of the survey, as usual, we have our pop-up screen come up, and that's to give us some feedback as well as to give the presenters some feedback about the webinar to improve going forward. And we do share that with our presenters. And of course, the webinar slides and the video will be available within the next 48 hours. And just as a reminder, we do have some upcoming webinars. We have one Wednesday, May 9th, the Essential Frailty Toolset, and we have one coming up Wednesday, May 23rd. Our general guideline is we like to have two a month, and they're usually Wednesdays at noon, unless there's some conflict and we can't schedule them that day. We do have our CFN 2018 National Conference coming up in Toronto. It will be, or the registration will be opening soon, probably on Monday. The details are on the website, and you can see the URL on our conference website page. As part of the conference this year, we're doing something a little bit different, and we're having an innovation showcase. And you may have seen the application process being sent out quite often in the last couple of months to get applications for this innovation showcase. The applications are due tomorrow. They're not that difficult or not that hard to fill out. There's probably 27 or 28 applications already received, which is unusual because the deadline is tomorrow, and a lot wait until tomorrow to actually submit their application. So if anybody's interested, please submit tomorrow, as we'd love to have as many as possible. And again, you'll see the URL on what the showcase involves. So I think that's it for me today in terms of CFN news. And so we'll go ahead and I will introduce today's two presenters. We have Todd Lee. Both of them are on clinic, so they're rushing to do this webinar today, but they're both there, I think, now. So Todd is an attending physician and the director of clinical practice assessment unit at the McGill University Health Center, and he's an associate professor at McGill University. And Emily is an attending physician at McGill University Health Center. She's an assistant professor of medicine, and she completed her residency training and master's in epidemiology at McGill University, as well as postgraduate training in patient safety and quality improvement at the University of Toronto. So Emily, I believe you're starting. And accept the presentation. There we go.
Yeah, and you can hear me okay? So, hi everybody.
Yes, I can.
Okay, thanks so much for joining us for this webinar, where Todd and I will get to share with you the results of our pilot study using an electronic application that we built called MedSafer. So conflict of interest, we co-developed MedSafer. It's an electronic application to identify deprescribing opportunities in older adults. And we received funding for this trial from the Canadian Frailty Network. We don't have any other conflicts of interest to declare. So today's objectives for the webinar will be to discuss the MedSafer pilot trial. We're going to be going over the background of polypharmacy and deprescribing, the objectives of the study and how we completed the trial. We'll talk about the preliminary results, which is pretty exciting for us, and some conclusions and future directions. So we do have a similar trial that's currently enrolling that was funded by the CIHR. So polypharmacy is a problem that is very common. We see it in a lot of the older patients that we treat in the hospital as well as in the community. Some people have said that polypharmacy can be defined as 5 or more drugs, but actually we see some patients on 10 or 15 or 20 medications, and so the definition of polypharmacy is a bit of a moving target. We do know that about 20% of community dwelling older adults are on 10 or more medications, so it's quite a striking phenomenon. It's very common. When we look at our patients on the clinical teaching unit, where Todd and I practice quite a lot of medicine, we see that more than 50% of patients who are 65 or older have polypharmacy, and more than 10% will be discharged on 20 daily medications. And so you can imagine if you're taking 20 medications a day, that you might be taking so many pills that it could feel like it's replacing your breakfast or your meal. Polypharmacy is a problem because the more medications you take, we know that there's a greater chance that you can have a complication from those medications, and these can lead to adverse drug events. We know that a lot of patients are coming to the emergency room or being admitted to the hospital because of an adverse drug event, and many of these are preventable, or some of them we could improve upon. And so the idea behind acting on polypharmacy and trying to reduce the number of medications that a patient takes, for one, is to try and reduce some of these preventable adverse drug events. And there are many other reasons that we will try and address polypharmacy that we can discuss today. Prescribing is a new term, but people have been stopping medications for a long time. In JAMA Internal Medicine, they had a paper more than a year ago where they described the process of deprescribing, and you could think about looking at all of the drugs the patient is taking and trying to figure out the reasons, and that's step one, and that's sometimes a barrier in and of itself, just to know why a patient is taking a medication. The next step you want to do is consider what the overall harm of the drug is, and consider what the future benefit is and the future harm. And then you want to prioritize which medications you might be able to stop, and doing so might factor in which of them have the lowest benefit to harm ratio. And finally, you're going to implement a discontinuation regimen. And then you need to watch your patients to see if they get better or if they have adverse effects from stopping the medications or reducing them. So it's very important to have that follow-up in place to see how patients respond to stopping their medications. So that's the process, and you can see that it can be pretty time-consuming if a patient has 10 or 15 conditions, medical conditions, and they're on 10 or 15 or 20 medications. That being said, when it is successful, you can stop what's called potentially inappropriate medications. And these are medications that you can find on lists of recommendations like the Beers criteria, Choosing Wisely Canada, or the STOP criteria out of Australia. And potentially inappropriate medications are really what we were looking at stopping in this study. So the background, when you start to cross-reference a patient's medical conditions, and as we said before, some of the patients who are admitted to the clinical teaching unit might have multiple medical conditions such as diabetes, high blood pressure. They may have a cancer that's in various stages of progression, or they may have a history of falls or cognitive impairment, and then you start to look at the number of medications they're taking and the indications. It can actually take a long time for the pharmacist or the physician to sit down and go through the medical dossier and the medication list and think about which medications might be harmful in this patient's particular circumstance. It actually requires a pretty good command of the literature as well, because there are some ever-changing recommendations for which medications might no longer be necessary for the patient or that might be harmful, because as we all know, there are new medications added every day to our formularies. So if you have a person who's sitting down and going over the past medical history and the medications, this can limit the scalability of a widespread intervention, because you need someone who's physically available and that you have the resources to pay to go through this process. So the point of MedSafer, which we built over the last 5 to 6 years from the ground up, was to develop a process that would identify these deprescribing opportunities and that would automate the process. We wanted a computer or software that would be able to cross-reference your patient's medical conditions, maybe include something about their lab test results like their creatinine or their diabetes control through their A1C, consider something about their life expectancy and their fragility or frailty, and based on that, come up with a list of opportunities for medications that you could stop. We wanted this to be based on the ever-evolving literature and to be evidence-based.
And so hi, it's Todd Lee talking now, in case you noticed the voice change. So for the purposes of this study, the intervention was going to be to utilize MedSafer to identify these deprescribing opportunities and present them to the most responsible physician during the indexed hospitalization. And we present them with a list of the medications that have been identified, along with the reasons for why they have been potentially identified as inappropriate, and the steps one would take if they needed to or were interested in discontinuing the medication. For example, does this medication need tapering? What type of symptoms would we look out for as we were coming off of the medication? And these deprescribing opportunities represented drugs which were identified for which the risk was probably greater than the benefit. Many things on the Beers list, for example, are drugs where the risk is probably much greater than the benefit. It also includes a whole class where the risk-benefit discussion is a little bit nuanced, depending on the patient and depending on the severity of their comorbid illnesses. But in general, many patients could stop these medications. And an example would be the proton pump inhibitors in older adults, where there may be a legitimate indication for the prevention of serious gastrointestinal hemorrhage in the context of multiple anticoagulants for coronary artery disease and vascular stents. And so for them, the benefit could be legitimately stated, whereas for other people where they don't have these indications, it may be safe to stop. And then we have another group which we called the little risk but little benefit category, and there would be really little value in continuing it. And a good example of this would be something like docusate-based stool softeners, which essentially don't work. So we also included links for the clinicians to some of the patient-level educational material available through the Canadian Deprescribing Network. So at the time that the patient was admitted to the hospital, for the purposes of this study, we had dedicated research personnel who would read their admission note, which, given that this study would be done at clinical teaching units across Canada, is often a very detailed note, and take some historical details about the patient's relevant illnesses. Obtain the best possible community drug list, which is the standard of care, at least in all of the hospitals that we participate in, that it's pharmacy-led, either a pharmacy technician that's been specially trained or a pharmacist does the best possible medication history as part of medication reconciliation that we do for Accreditation Canada. And then the application would generate a cross-referenced list looking at combinations of medications or combinations of medications and patient comorbidities, or just medication lists to identify drugs where there might be an opportunity to deprescribe, and would present them in a prioritized sequence. So the MedSafer Pilots, funded by the Canadian Frailty Network, and involving collaborators at the University of Toronto and the University of Ottawa, including James Downer in Toronto, Alan Huang and Alan Forster in Ottawa, Louise Pilots and Robin Tamblin here at McGill. We used 4 sites at these 3 universities to recruit older hospitalized adults to a study looking at whether screening their medication and medical history using this tool and providing the deprescribing opportunities would be associated with an improved reduction in potentially inappropriate medication use. The study was originally designed as a cluster randomized step wedge trial. It was very interesting as we went through the pilot. The research ethics boards didn't really know what to make of a study where we were recommending or providing information on stopping medication. So there was a little bit of a delay with that, and we ended up having to go before-after design because the 3 sites were quite staggered in terms of when they got ethics review. But the purpose of the pilot was to develop and test the software in real patients to determine whether this type of intervention, which is just providing information, was acceptable to patients and physicians, to get a sense of patient enrollment and eligibility numbers amongst patients in these catchment areas, and really to understand the barriers to deprescribing and some insights into patterns of polypharmacy. So we ran from September 2016 and concluded in May 2017. The primary outcome was the proportion of patients who would have 1 or more potentially inappropriate medication discontinued when they left the hospital. And discontinued included a tapering plan to stop.
So this is the study flow chart, which I'll take you through. To begin with, each of the centers had a period of baseline data collection, which was the control phase. So really all we did here was we looked to see what physicians and residents did with medications when they weren't cued by any means to stop them. And so we got a baseline rate of deprescribing for each of the sites. Patients who were eligible for the study were those who were admitted to a study unit, who were 65 years or older and on 5 or more medications. For the baseline period, we used the software for data collection only, and we didn't generate a list of deprescribing opportunities. For the intervention period, we did generate the deprescribing report, and we handed it to the treating team. So this included the unit pharmacist, as well as the resident who was taking care of the patient and the attending physician. When the patient was discharged from the hospital, we took note of any changes that had been made to the medications by the team, and we faxed a summary of the medication changes and the deprescribing opportunities to the doctor and the pharmacist that the patient identified as their usual treating clinician, doctor or nurse practitioner. We consented a subset of patients for a 30-day follow-up phone interview. So for this, the patient or their proxy needed to be able to speak French or English, and they had to be available for a follow-up phone call. And this was for us to determine whether there was a reduction in adverse events or adverse drug events. And although we weren't powered to look at this in the study, it was important for us to go through this process, as the bigger study that we're enrolling for now is actually powered to look at a reduction in adverse drug events. So we were using our interview software for this. The telephone interview took place about 30 to 35 days after the patient was discharged from the hospital, and we made up to 8 attempts to reach the patient or a proxy. And this was an interview that had been used in a previous study called RightRx, and it was a structured interview that looked to see if the patient had any symptoms that had gotten worse, any new symptoms. We took note of any visits to the doctor, and especially any returns to the hospital, to the emergency room or readmission, and changes that occurred to the medication after the patient left the hospital. In addition, during the interview, for those patients or proxies that were able to answer it, we also asked them the PROMIS sleep questionnaire, because a lot of the medications that we were intervening on were sleeping sedatives. And we also asked them the EQ5D quality of life questionnaire to see if maybe we were improving quality of life by stopping pills. Other secondary outcome, for the secondary outcome for this study, which was adverse events post-discharge, we used the Leap and Bates approach. So we had blinded interviews that were reviewed in duplicate, and we looked to see if any adverse event had happened. And then we decided if on the level of 5 or 6, it was related to a medication, then we would call the adverse event an adverse drug event. And these were done in duplicate by 2 reviewers, and then there was a 3rd reviewer who adjudicated any differences in opinion. So I'll hand it over to Todd to discuss the results now.
So we were able to screen approximately 925 patients who were over age 65, admitted to these sites, took 5 or more drugs, and were eligible. And of this 924, 779 of them would have had 1 or more potentially inappropriate medication identified based on their admission drug list. And so these represent the group of patients that we're going to be talking about from here forward, these 779. What we can see here in the table 1 is that this is quite an old cohort of patients, actually. I hadn't expected the median age to push 80, but as you can see, the median age in both the control and intervention period was approximately 80, with 25% of patients being 86.5 or older in the control group, or older than 88 in the intervention group. Relatively gender balanced, quite with a slight female preponderance, which I guess makes sense in terms of life expectancy and survival. And as you can see, without going down the entire table, they're a fairly polymorbid population with a lot of congestive heart failure and ischemic heart disease, a lot of diabetes in 40%, and a lot of cancer. A fair number of patients had a history of mild cognitive impairment or dementia, as well as had previously had delirium. That was about 1 in 5 to 1 in 4 to 1 in 5. And more than 25% in the Rock-Hall frailty score were scored as moderate to severely frail. That makes sense for a group of people who stayed at least 7 days in the hospital, because there's incredible pressure to move patients out of the hospital. And when you say 7 days here, this is usually why. I don't know how many of you are familiar with the Homer score. The Homer was a score that was published in the CMAJ a few years back, validated in Ottawa and many hospitals around the world, and it predicts the 1-year mortality of a hospitalized patient. And so what we can see here, I don't know if you can see my pointer, I'm going to pretend that you can, is we can see that 50% of the patients, or the median estimated mortality in the next year, was 37%. Or to put that another way, about 20% of the population had a predicted mortality of 50% at 1 year. That speaks to age and the number of comorbidities and the fact that they were admitted to the hospital, really. This is a frail group of patients with a relatively limited life expectancy. This is the table of the most common, potentially inappropriate medications identified, not sorted by priority or risk, but just by proportion. I don't think it would surprise many people to see that the proton pump inhibitors were used by more than half of the patients in this study. I was quite surprised by the number of patients who were taking iron supplements, potentially with no anemia that's possibly related to a deficiency in iron or other indication. But then a lot of patients who are on potentially inappropriate atypical antipsychotics, potentially over-treated for diabetes with oral antihypoglycemics and A1Cs below 7%, and the use of antiarrhythmic drugs, for example. Is it still me talking? Excellent. So I love this slide and I hate this slide. I love this slide because we were able to stop 54.7% of patients. We were able to stop one or more PIM in the intervention phase. And I love this slide that in the control phase, we were also deprescribing, but I hate this slide that in the control phase, we were also deprescribing. Because I think that the effect of what we were trying to achieve could have been bigger. We're victims of our own success. We've been running inpatient deprescription programs at McGill since about 2013. So in some way, maybe they were primed, and so we did better because of that. But in some way, I think that the historical control is contaminated a little bit. But anyway, the odds ratio for discontinuation of a medication after adjusting for clustering at the level of the hospital was 1.24. And the absolute increase of 7.8% of patients having one or more potentially inappropriate medications stopped gives a number needed to treat of about 13 to stop one medication that's potentially inappropriate in these patients. So we think that that's a reasonable number needed to screen in order to have an effect. Now, 595 of these patients consented to the follow-up telephone interview. 45 of them died during admission. That's about 7.6%, and that's kind of average for the mortality over the last 5 to 10 years on our clinical teaching unit. It's about 7 to 9% depending on the month. We were able to interview 80% of them, which is great. 32 of those people that we were not able to interview, it was because they died within 30 days of discharge, giving an overall mortality, 60-day mortality, an overall mortality including the admission of about 14%. And the adverse events were about 36% in the control and 33% in the intervention, which is higher than, say, Alan Forster's estimate of post-discharge adverse events. This is probably because we're a really selected frail, polymorbid population, and theirs was more of a study of most patients. And then adverse drug events were about 7.5% in the control versus 4% in the intervention, which is an exciting mathematical observation, but completely statistically insignificant and could have just as easily been the other way. But it won't be, but it could have been. Importantly, there was really no difference in the self-reported level of sleep dysfunction between controls and intervention patients. So even though we were going after medications that are used at night with sedating properties such as benzodiazepines, Z drugs, and atypical antipsychotics used for sleep, there was no real appreciable difference in the self-reported quality of sleep between these two groups. And just to give you some sense, the average person is considered a score of 50. So these people are around the, the Canadian average in terms of the type of sleep that they report. And we were able to get quality of life data on almost 60% of the patients. What was interesting here is that the median quality of life as reported 30 days post-discharge was 0.64 in the control group and 0.75 in the intervention group. So numerically a little bit better in the intervention group. And to just give you some context, for Canadians who are community dwelling age 80 to 85, the median value of that utility is listed at 0.848. You might ask what those numbers mean. I think they mean if you were to assume that a life in excellent health with no limitations or problems whatsoever is given a utility of 1, this is what these scores mean. They're less than 1 and proportionately so. And I have these histograms here, but being mindful of the time, these are the histograms of each of the individual domains with the one indicating intervention. And it was interesting that the major differences that were driving the composite EQ5D5L difference were mainly in the ability to provide self-care, where there were more people saying, I have no problem with that, and less people saying, I have severe limitations. That's what a 4 and a 5 means, and with their ability to perform usual activities of life. Whether or not that's just, chance is again definitely a possibility, but it would be interesting or compelling to think that stopping some of these medications might allow people to participate in more of their usual activities of life. We'll have to see that in a much bigger study that's designed to answer that question.
Okay, so I'll take over from here and we'll discuss a little bit about some of these results we've talked about. So we feel that the intervention was successful, and this was in spite of a very short intervention period. And we were able to stop patients' potentially inappropriate medications as identified by MedSafer. We felt that a number needed to treat of 13 was fairly reasonable, given the intervention is pretty minimally intrusive. When we discussed with the treating team and the pharmacists, it was quite acceptable. They didn't mind receiving the deprescribing opportunities, and in fact, many welcomed it. A lot of the recommendations they were following, and sometimes they would see recommendations that they had no idea that their patient was taking a certain medication and it might be interacting with another. And it was, a small amount of effort to provide these opportunities for deprescribing. And it really encouraged us to continue working towards automating the process of deprescribing. Some of the limitations of this study, Todd mentioned before, this was originally meant to be a stepped wedge trial, but we had to change it to a study that was before and after. And this was because we had difficulty getting the RAB at all of the sites at all at the same time. We were a bit disappointed by the number of patients who we obtained sleep and quality of life from, but considering the patient population, I don't think it's that surprising. And so it is good that we were able to get this data for patients in proxy that were able to participate. Just to remember that the study wasn't powered in order to look at individual drug classes or for adverse events or adverse drug events. But we do see some trends, and hopefully in a study that's powered for this, we'll be able to show a difference in this hard outcome. And one of the limitations of the study, as Todd mentioned, was that it took place on units that had a very high baseline level of deprescribing. And so if we use this intervention at other sites where there isn't this culture of deprescribing, we hope and we think that we'll find a stronger impact. So some of the strengths of the study were that we were able to recruit many older adults, a lot of whom were moderately to severely frail. And these are the types of patients who are not often included in studies. We included patients with cognitive impairment and patients with limited life expectancy who are probably the most vulnerable to side effects from polypharmacy. The automation process was successfully deployed in 4 hospitals. Even though there are very different practice habits and local cultures, we were able to use the deprescribing opportunity report in all of the centers. And even though we had really high background rates of deprescribing, we were still able to increase the amount of drugs that we stopped using the reports. So we think that the software is safe. It's easy to use. It was pretty feasible and acceptable to the users. We were able to increase the performance in stopping potentially inappropriate medications. And now we need to power for adverse drug events, because stopping medications is great in and of itself, but we really want to show an impact on a safety outcome. So I alluded to this study before, but this is it's more of a current direction than a future direction, but we were funded by the CIHR for an 11 hospital study, and this is a stepped wedge randomized control trial with 3 clusters, and we'll be enrolling 6,000 patients across Canada. Right now we've enrolled just over 2,000, and we are powered to detect a 25% reduction in adverse drug events at 30 days post-discharge. So we're very hopeful to show that. Some of the other work that we're doing with MedSafer involves long-term care facilities. So we developed a customized version of the software, which is going to be used in all of New Brunswick long-term care facilities, and we'll begin providing deprescribing reports in 2018, probably around the summer. We partnered with York Care Centre, which is going to be the first long-term care centre to deploy. And this is a partnership that came out of the CFN meeting. This is where we met Kevin Harder and got together, and that's how we will be working in New Brunswick. We're going to be using administrative data, and this study was funded by the New Brunswick Health Research Foundation. And one of the other populations that we're looking at stopping medications in are patients who are admitted to the hospital, but then who get moved to an off-service or alternate level of care bed. There are actually about 30% of hospital beds in New Brunswick that are occupied by patients that no longer require acute care services. They're waiting for placement in a long-term care facility. And these patients can actually spend a couple of months in the hospital. And this could be a great opportunity to have a medication review that could be guided by MedSafer. And one of the final directions that we're looking at is to deploy MedSafer at the Ottawa Hospital in the preoperative clinic. So we've been working with our partner anesthetist, Dr. Dan McIsaac, looking to see if patients who come to the pre-op clinic, if they can stop potentially inappropriate medications identified by MedSafer prior to surgery. And the hope would be that this would reduce delirium and falls in the hospital by stopping some of these medications well in advance of their surgery. So this is our team, and we had a great number of research assistants helping us and research coordinators. We'd like to thank everybody from all of the different sites who helped us complete the study, and for those who have gone on to continue working with us on the CIHR study, and especially our developer, Alec Lefebvre, who's been working with us to develop MedSafer. And we're going to end here, and if there's any questions or comments, we're going to take them now. And if we don't have enough time to answer your questions here on the webinar, then you can email us, and we're happy to answer the questions that way. So thanks, everybody.
Thank you, Emily and Todd, for the informative presentation. And you've already alluded to the fact that if we don't get to all the questions today, that you would offer up your emails, and it's on the slide now. Just reminding everybody in the audience to please continue to send in your questions as we go along, and we'll get to as many as we can. So the first question I have, and this is a fairly basic question, I guess, from the presentation, is what were some of the major technical challenges to be overcome in creating MedSafer?
Yeah, am I still screen sharing with you?
Right now, your email contacts are up there. Did you want to put something up?
Yeah, I was hoping just to show you a slide to answer your question about the technical difficulties.
Sure, we'll just transfer it back to you now.
Well,
Okay.
Hold on, do we have that slide?
Okay, here it is. I don't know, can you?
No, we don't, that's not the right slide.
No?
No, that's not the right slide.
That's the API.
I know, that's not the right slide.
Okay.
We'll go to the contact slide, but I can't. Anyway, there we go. Okay, so I mean, there are one of the major challenges is the heterogeneity of the data sources, and so what I mean by that is that drug lists are stored in multiple different ways, and drugs can be referred to by multiple different means, and actually so can patient comorbidities. They can be referred to by multiple different names, by multiple different coding schemas, and can be alluded to by multiple presence or absence of multiple different complications. And so I think one of the first technical challenges we really had to overcome was coming up with a way to distill down these complicated schemes of classification into the simplest possible but accurate bit. Because we really needed simple means of collecting the past medical history and cross-referencing against medication lists that were as accurate as possible, but grouped in such a way that it was reproducible, whether we did it in French in Quebec or whether we did it in English in Quebec or English in Ontario. So that was probably the first hurdle. And then the second hurdle was coming up with the language, I think, to describe how to take these documents like beers and Choosing Wisely Canada and turning it into something that interfaces with that. And then probably the third hurdle was coming up with a very pleasing way to convey this complex message or this work product to the user that facilitates them actually. I guess it's not a technical challenge, but when you try to make graphical output of something, you realize it's actually a technical challenge to give them enough information that it would be useful to them, but have it be somewhat attractive. We still use facts. You know, it's 2018, we still use a lot of facts. So figuring out how to make these things so that I could print them and give them to you, or I could fax them, or I could transmit them by electronic mail was actually also challenging. I hope that answers the question.
Yeah, and I guess the question also is I know right now you're using this in a, kind of a controlled environment, but is the intent at some stage to get it so that this MedSafer is, for somebody like myself to go on and be able to put in, the medications I'm on and have something come back to me as advice, or is that?
So we have now, once we dealt with the initial issues and then we were able to use it in the actual pilot, we've actually built an application programming interface. That's a fancy way of saying we have a way to speak to other programs now where we can tell them how they should be structuring the list of things to send to us and maybe even do some translation on our end and give back recommendations. So that's going to allow us to look to partner with multiple other people, including potentially vendors of electronic medical records or with provincial governments. And then on the user-facing side, it certainly would allow us to look at developing some sort of user-facing application that they could use in concert with their patient-facing, that they could use in concert with their physician. And so that's on the list of things to be done.
Okay. I was just listening to a podcast there last night on Robin Urquhart's on the Evidence Network, and it talked about, going to an electronic prescription system and so that you would be able to, even as a patient, be able to go in and look at it. And she also, I think she was talking about, getting accurate numbers for adverse drug events and really that not being, really true that, maybe I think you said 1 in 7 ER visits, but that I think she went on further to say that the clinical trials were not enough and more follow-up required to really tease out that number that is for adverse drug events, because a lot of it doesn't seem to be reported. And I'm not sure if that's what you've, come across as well.
Yeah, we found that we were able to determine if the patient had had an adverse event. So it was a lot easier to capture a return to the emergency room or a visit to the family physician or readmission to the hospital. But because the past medical history and the medication lists are so complex, it can be a lot more challenging to pin an event on one medication. And, we find a lot of the adverse events like falls for a patient who's on 15 or more medications. It can be really tricky to say, well, that's definitely due to that medication and not due to a host or a constellation of factors.
Yeah, that does pose some problems. And it was some a further question that came up about, just about your process here is what is the process for updating MedSafer deprescribing recommendations as new information about potentially harmful medications come out?
Well, we're really lucky in that the way we've designed it is it's essentially modular. And so, for example, in between the pilot and the starting of the CIHR study, we added 4 or 5 different recommendations in real time with citations. Even before even before they necessarily made it onto one of these lists. We've been looking at the opiate and benzodiazepine crises that are facing North America, and the increasing evidence that co-administration of both is actually multiplicative in the risk of harm. And so, for example, we could build a rule after we got off this phone call that would, immediately start to identify those patients. So we're really lucky in the way that we did the design. We can add or remove or change the way rules are behaving. And that was actually an incredible part of the pilot that we didn't talk about, was the feedback we'd get from community physicians or community pharmacists. And they would say, in this patient, I wish it didn't say, it was that message hadn't been there, because did you know they also had condition Y? And that led us to realize that if you could suppress, sometimes putting out these indications if there's a clear other reason that would explain why they're taking the medication.
Yeah, just like as an example, we were originally flagging Lasix in patients who had no history of congestive heart failure, and then realized that we should also suppress that rule for patients with cirrhosis. So, someone pointed out that's the obvious indication, and we were capturing that past medical history, so we were able to change it so that the rule would no longer appear for patients with a history of cirrhosis. So it's pretty flexible and easy to update in time.
Wow, that's excellent. So I know we're getting close to the time, so I kind of leave you with 2 questions. Maybe what are the next steps for moving the research forward, and some final thoughts on that with everything you've heard today?
Well, I think for us, the next, we alluded to some of the future projects. I think the one that we're most excited about is involving long-term care facilities. I think that long-term care facilities have a lot of opportunity to look at appropriateness of prescribing. And I think that the way that we've built the solution now with the application programming interface and with the partnership with York Care and the AgeWell Hub in New Brunswick is going to allow us to really automate a lot of the process with existing data sources. So I think that's potentially a very exciting opportunity, and they're an English and French province too, so that really helps us develop up both languages. We are bilingual, but sorry, we are bilingual.
That is a good place to start with both of them.
Yeah, but getting validated in French is going to be really important.
I think that also patients and their caregivers and family members are really interested in getting involved in the process, and so working on a safe patient and family-facing interface that allows them to be involved in the process, maybe bringing a list of medications that could be stopped or discussed to their family physician is a high priority for us right now.
I think some thought about I want to be transparent with patients, but I think we have to take some lessons from Kara Tenenbaum's Empower study about what patients do with information, and that, she said that there were a number of patients that discontinued their benzodiazepines immediately without speaking to their pharmacist or physician, and that's okay. But I think we should just think about when we're providing these type of recommendations for the opportunities, I wouldn't want someone to stop their clopidogrel and have their stent thrombose without discussing the risks and benefits of that with their doctor. And so nuancing how we give patients the most information we can but ensure that the physician and pharmacist is part of the conversation, I think will be really important. And worthy of, you know, like anthropologic style research and a lot of qualitative research to understand how these decisions get made, both by patients, their families, and their practitioners.
That's thank you for sharing your work and your passion for this area. It sounds like you're all in, and hopefully that you'll be able to continue this work. So again, the emails are, you can see them at the ones that came on our list today. And so again, thank you very much for presenting today, and thanks everyone for coming on. That basically concludes our webinar, and hopefully you'll be able to join us for our next webinar, which I believe is maybe May 9th. And have a great rest of the day, and that's it for today. Bye for now.
Bye, thank you so much.
Thank you.